Professor Dr. Sharda Jain. Though she needs no introduction, it's my proud privilege to read out her introduction. She is fondly known as teacher of teachers, mentor of many of us students.
Jyoti Bali की जरूरत नहीं है, madam. Please, please.
अच्छा चलिए मैम, I will not take even half a second. I'll just finish it off. And of course, DGF, the entire Delhi owes it to her that she brought us together on this platform. And this infertility committee, me and Dr. Poonam will be taking through every month, 20th. If it's a Sunday, then we'll take it on Monday or Saturday, depending on the speaker's choice and the day convenient to all of us. Next, of course, will be by Dr. Shivani. So, Madam, I welcome you for this lecture today, which you've taken on. You are going to take on lean versus obese PCOS. So, the chairpersons for the session are Brigadier Dr. R.K. Sharma, sir, and Dr. Jyoti Agarwal, Dr. Shivani Sachdev Gour. I welcome all the three chairpersons as experts to the session, which Madam will be speaking on, lean versus obese PCOS. Dr. Brigadier Sharma, sir, of course, is an integral part of DGF.
We can go ahead with the lecture.
Director HOD, Institute of Reproductive Medicine and IVF Center at IVF Center in West Delhi. He is the founder, director at ART Center at Army Hospital, advisor ART program of medical colleges and private centers, former General Secretary IFS. And I also welcome Dr. Jyoti Agarwal. Is she there? Dr. Jyoti Agarwal needs also no introduction. She is the senior consultant and director at Life Care Center. Dr. Shivani Sachdeva Gour, again an eminent infertility specialist from Delhi. She is director SCI Healthcare, fellow member Imperial College, founder secretary Delhi State Chapter of ISAR, secretary Delhi State Chapter of ISPAT, general secretary INSTAR, ex-vice president Delhi Gynae Forum South, vice chairperson of Women's Doctor Wing IMA. So welcome all three of you, the chairperson and the experts. Over to you, sir. You may invite ma'am now.
Great, good afternoon, everybody. Today I'm going to talk on a problem which I call is a gynecologist dilemma. It's a complex endocrine, metabolic, reproductive and psychological system disorder which bothers nearly 5 to 25% of people. As far as our country is concerned, in adolescent it is said to be, the incidence is said to be as high as 25 to 30%. Now, there are two definitely entities known, lean and obese PCOS, and there are many myths and facts which I think I will try to summarize in today's presentation. It's a short presentation. We all know that PCOS belongs to WHO Group 2, where it is said to be normoandrogenic, normoestrogenic, and ovulation. And we know there are classical cardinal three features of chronic anovulation, androgen excess, and the polycystic ovarian morphology is there. If any two of them are present, then we say that, person has got polycystic ovarian disease. In the last 50 years, since the time I became a gynecologist, I have seen, from no entity became a great entity. And then every year it is confusing left and right. It's a commonest endocrinopathy, as just now said. The incidence as far as this country is concerned, we should say it is 20%. And it is the commonest cause of anovulatory infertility. Most women are obese, that is a BMI of 30 for outside. And for us, the BMI of 27 when we say that they belong to the category of obesity and not overweight. Nearly 50% have obesity, but 20 to 30% belong to lean phenotype. There are various people have tried to classify it according to the phenotypes, and I think many of you must be knowing about it, that the 6 features are taken into consideration: the androgen levels, the LH levels, the ovarian size, the AMH, the body weight of a person, and insulin resistance. Now, it is all 6 are present. We call it as a classic phenotype. If in this classic phenotype, ovary are normal, then it belongs to phenotype B category. And the phenotype C categories are, all rest of 5 features are raised, but the LH is normal and is said to be ovulatory. And in type D category, 3 features out of the 6 features are normal. There's a normal LH, normal AMH, and the normal weight. As majority of us do not do that kind of detailed investigations, LH is not done anymore. Androgens, if it is it's on her face that the androgens clinically are more, then again we are not trying to test this parameter. So we were told by B.N. Chakravarti, he's no more great infertility expert as for this country is considered, and just like Brigadier Sharma, he also had been a guru of many IVF experts. He used to say group A is only where there is a delayed menstrual cycles, 35, 45 days, and the rest of the features are normal. So whenever there is a delayed menstruation and you find there are features of PCOD on ultrasound, these cases are very typical and they respond very beautifully with clomiphene. And I think, his words have, in my own experience, also have proved almost 100% as far as these words were concerned. And he used to say the group B belonged to mildly androgenized with hirsutism, with mild obesity. Here the ovaries are slightly enlarged and there is a stromal hyperplasia. These patients may still respond to CC, but better option to use letrozole in today's time, and or combined with metformin in case if you find that these people are having resistance or a failure. Group C are the typical obese, stocky subjects with a family history of diabetes, family history of PCOS. They may present with amenorrhea or they present with withdrawal bleeding. Only when you take the drugs, then only the bleeding will occur. And they have typical oligomenorrhea and hair-on syndrome, all classical features on the neck. The tags and all are all seen. We also know that, as far as the broad outline of treatment is concerned, there's a consensus all over the world that in level 1, as far as the PCOS is concerned, either you use letrozole, which is choice, but one can use CC as well. And in case if it is not responding, then one can add on metformin in case if there is an abnormal glucose tolerance or there is a central obesity. In this category, there can be a combination of gonadotrophin, CC or letrozole along with metformin. The second levels are gonadotrophin, pure use of gonadotrophin as an ovulation induction or using a laparoscopic ovarian drilling. As far as the down regulation and plus use of gonadotrophin with metformin is concerned, it is said with IUI things should be kept as simple as possible, and it should be only left for IVF cases. And level 3, we all know that patients require IVF, and that also segmented IVF yields better results. So in short, according to B.N. Chakravarti, the group B and C, 30 to 40% will not respond, and they will require IVF. And I find this later classification to me suits tremendously, much simpler, and what line of treatment you have to follow. Now coming to the myths between the lean and the obese PCOS, it is said that obesity causes PCOS. The answer is the obesity is not only a factor that plays a role in PCOS causation. There are other factors such as genetics, epigenetics, exposure to androgen in utero, and environmental factor which interplay causing PCOS. Epigenetics is very important, and I think it can be a topic of discussion even one day, how people who are genetically prone, in case if epigenetics, person works on it, things can may make a presentation or may not make a presentation. It is true that the obesity and the weight gain helps in sustaining PCOS. Moreover, obese PCOS do find it difficult to lose weight and thus forming a vicious cycle. The myth too is that the symptoms in lean PCOS are different from obese PCOS. Symptoms in both phenotypes of PCOS are more or less the same. Category A to category D. Menstrual irregularity in form of delayed periods, acne, hirsutism, thinning of hair, weight gain is seen in obese PCOS. The incidence of severe menstrual irregularity like amenorrhea, AUB presenting as continuous bleeding or hirsutism is more commonly also seen in obese PCOS. Third myth is AMH levels can be used to diagnose PCOS. AMH levels are significantly higher in PCOS than non-PCOS counterparts, and the serum AMH, anything more than 5 nanogram has been suggested as a cutoff, where all clinicians should be alerted that these are the candidates who can definitely go into something like OHSS in case if close monitoring is not kept on them. For a diagnosis PCOS, AMH does not find any place in the Rotterdam criteria. So I make it clear again that for a diagnosis, AMH does not figure in the Rotterdam criteria. It cannot be used as an independent marker, but only as an adjuvant marker. Interestingly, lean PCOS have a higher AMH levels, which could be explained by the fact that the lean PCOS may have a higher LH levels and thus high LH FSH ratio, which positively correlates with AMH levels. The fourth myth is the insulin sensitizer should be prescribed to obese PCOS alone. Now, obese PCOS have a higher incidence of insulin resistance to the tune of 90%. I will say much more than this, as compared to the lean PCOS, where it is found to be around 50%. The insulin resistance has associated hyperinsulinemia and hyperandrogenemia, which I said in the initial part of it. They are the key players as far as the pathophysiology of PCOS is concerned. It has been found that at least 50% of PCOS women, insulin resistance appears to be related to insulin receptor defect to both the phenotypes of PCOS with insulin resistance. So it is the insulin receptor defect. Obese PCOS are at risk of developing metabolic syndrome than lean PCOS. This is again a myth. We all know that the central obesity, which is the component of metabolic syndrome, is seen more often in obese PCOS, although lean PCOS are not spared. Metabolic syndrome includes central obesity, that is waist-hip ratio of anything more than 0.8, hypertension, that is BP of more than 130/85, dyslipidemia, where triglycerides are more than 150 and good cholesterol is less than 50, and impaired glucose tolerance at its 5 components. Any 3 components are present, the person has a metabolic syndrome. Metabolic syndrome affects 33% of women with polycystic ovarian syndrome patients, and mostly these are obese patients. Lifestyle modification are only for obese phenotypes. This is a myth. We all know that the lifestyle modifications are advised to both the phenotypes. These include diet, exercise, and the weight management. Even 5 to 10% of weight loss may help the obese PCOS patient, and it has a magical effect. I think all of us have seen that the moment a lady who is more than 80, she decreases her weight by just about 5 to 10%, and you find everything works for her. Whereas the lean PCOS are advised to have a weight maintenance. Both the categories are advised to refrain from unhealthy diet, such as high carbohydrate diet and fatty foods like saturated fats such as cream or cheese, and fatty red meats, as well as processed or fried foods, junk food. These unhealthy fatty foods increase the estrogen production, worsening the PCOS symptoms. Instead, they are advised the Mediterranean diet, which includes fresh fruits, vegetable, nuts, seeds, and healthy oils. This diet is very favorite to me, and I always prescribe that, whatever foods are concerned, and as far as raw vegetables are concerned, weight multiplied by 5 should be done. The consumption of fruit should be done right from the morning itself till 12 o'clock. And then lunch should be preceded by a good amount of salad, which is 5% of your weight, and then whatever diet you want to take, and the dinner should be lighter. And I find, this has a magical effect as far as the weight loss is concerned. But I still feel that, people who are obese and more than 80 kg should be referred to dedicated weight loss unit where, because they charge money, they will see to it that the effect is also there and they respond very well. You should try to discourage people who say, "Hum log doctor sahab apna weight khud hi maintain kar lenge." In fact, they keep on increasing in all their efforts. So both the phenotypes of PCOS are advised exercise, which helps for them to have a weight loss, improving muscle mass, improving capillary circulation, reduce body fat, and insulin resistance. Obese PCOS are advised beside an hour every day, 30 minutes of moderate intensity exercise at least 3 times a week, which includes aerobic exercise as well. Lean PCOS are advised strength training to build up their muscle mass. Myth 7 is that the PCOS drilling benefits the lean PCOS more than obese. Literature does not support this, that the PCOS drilling benefits the lean PCOS than the obese PCOS patients. In today's scenario, laparoscopic PCOS drilling is no longer preferred line of management of PCOS. But it can be done if laparoscopy is done for some other reasons like tubal factor or with coexisting other factors, or in cases where there is a clomiphene resistance PCOS are there. As far as myth 8 is concerned, and everybody very strongly feels, all my experts and people are listening, then the lean PCOS tend to hyperstimulate more than obese PCOS. In fact, it is a donor dictum. In my own center, I find that Dr. Jyoti does not take any donor where the weight, the body weight is less than 35 in these patients. Because they tend to hyperstimulate, and once they land up in OHSS, it is very difficult to manage these young lean PCOS patients. So the lean PCOS are more at risk of hyperstimulation than the obese. There is no doubt in it. And so the dictum of using low-dose step-up protocol with gonadotrophin seems to be the right choice for lean PCOS for ovulation induction in clomiphene-resistant patients. So for a donor dictum, it should always be remembered, do not take lean PCOS as your donor. In IVF cycles in lean PCOS, NTAC protocol risk of developing cancer in later life. We all know that obese PCOS are more at risk of developing endometrial hyperplasia and endometrial cancer more than the lean counterparts. This could be explained by high estrogen and low progesterone levels seen in obese PCOS patients. The risks are accentuated by the higher risk of metabolic syndrome in obese phenotype. However, the association with PCOS and either breast or ovarian cancer is rather complex and requires more well-designed studies done at a national level or internationally. This is lately I have found that dysbiosis and inflammation plays a major role in obese PCOS. As we all know that, our elders used to say that 80% of the diseases are come from the gut. And now, till now we've been talking about high levels of androgens, high level of insulin, obesity, and hereditary. Now the fourth factor has been added, that is chronic inflammation. And the markers to say that there are elevated levels of inflammatory mediators are there, like TNF-alpha is raised, IL-1 and IL-6, and increased CRP is noted. It is said that whenever a patient takes an unhealthy diet, the good bacteria becomes less, the bad bacteria increases, and this gives rise to dysbiosis in the gut. And these gut abnormal flora triggers gut permeability, and the obesity is the result, plus, because of the transepithelial passage of LPS. There's a gut inflammation, there's an insulin resistance, and this insulin drives testosterone production in ovary, impairs the follicular development. So the treatment will be that probiotics improves good bacteria in colon, and this in turn will see to it that there's improved insulin sensitivity, increases the production of satiety hormone, and reduces the food content and fat. And this returns to normal ovarian function. And this will be in future. I'm going to talk on this particular aspect, dysbiosis as a cause of polycystic ovarian disease. And that's why I call PCOD is an enigma. Every year there is something added to it, and we do not know where we are heading as far as PCOS is concerned. So this was in short. I had tried to compare between the two, but if you ask me in the end of it, I will go by what B.N. Chakravarti has said. But I think I will love to hear what Professor Brigadier Sharma wishes to speak on this particular aspect. So thank you very much.
Thank you, madam. Excellent talk. In fact, you made such a difficult topic so simple and so practical, so that the basic clinicians, especially the Dr. Chakravarti's classification, can be used in a daily practice, even by a simple gynecologist. So despite all the information which is available, your inputs about the diet, how to calculate the fruits and the salads, that also is definitely going to help us to, help this patient lose their weight, especially this obese PCOS patients. Now the PCO, as you rightly said, may not have all the parameters, and we have to go by a clinical aspect also. And then the stimulation also sometimes, you may find the patient otherwise was normal looking and having normal hormone, and then she suddenly, hyperstimulates. So it is a sort of a, whenever we are managing any woman, as far as gynecological issues are concerned, or the infertility issues are concerned, so we have to be very careful, and to be very careful in stimulation or in treatment. Now this new field which is opening up, the dysbiosis of the uterine cavity also, and this possibly was known to our old ladies earlier, and in between we started using all the veggie wash and this wash and that wash, which spoiled all the vaginal flora, and which is causing more and more problems in the normal healthy vaginal flora of the uterus also. Now, if we look at the ovary on ultrasound, in PCO, what I find another way of looking at the PCO is how the follicles are arranged. The typical, the pearl string pattern, which is there with the thick stroma inside, we know that this is going to be an androgenic PCOS, and this is the one which will be, poor responder when you start stimulating. And there's another one where, when you do the ultrasound, you find that all the antral follicles are uniformly distributed. And this is the one which is likely to go to hyperstimulation. So by looking at the ultrasound picture of the ovary, you know that which is going to be, both PCO but a poor responder, and a PCO or a hyper responder. And second part is, if you add little color doppler to that, if you find the color flow is much high in the ovary, that is the one which is going to be hyper responder. So one has to tailor the medicines according to the patient's pattern. Now some patients they are obese and PCOS, and they are not able to reduce the weight at all, whatever we may do, and they are morbidly obese. Now these patients, yes, definitely lifestyle modification is the first line. But despite all that, they're not able. So maybe some role of bariatric surgery for these patients may be there. But then if they're going for bariatric surgery, we have to tell them that we cannot do their infertility treatment at least for 1 year. After the bariatric surgery only they should be. Otherwise, the hormonal balance is there in these patients. So with this, I think very nicely you have described and made it so simple that even the gynecologists at the grassroots level would know, okay, this patient I can manage with letrozole and clomiphene, this patient would not do very well and should be referred to a higher center for maybe IVF. Thank you very much, ma'am.
Dr. Shivani.
Yeah, madam, thank you very much. Excellent presentation. Only the points I wanted to highlight was that lean PCOS, as you said, lifestyle management is still important for them, and metformin does not cause hypoglycemia because they also suffer from insulin resistance. And when I was studying, I read that this evidence-based approach now is myo-inositol is also being mentioned, but the dose is 3 grams per day. So when we are giving myo-inositol, it is coming up in some Elsevier Springer publication on evidence-based approach. So it is 3 grams per day. The slides, madam, are extraordinary. You think they are so simple, but they are the best to explain to patients. They are all on Google and I use them, I think, every day. If I want to explain any concept, I just open the slide with that big bold letters and the diagram to explain. Now, this slide of diet is going to be invaluable. And inflammation and probiotics, they are like a tsunami or a flood in the market. Every day, there are 30 new types of preparations which have come. So really, madam, this also be really good to explore the role of probiotics. So thank you very much.
I think I will request Brigadier Sharma to come out with a diet of this probiotics. I think I'm going to work on this. We will like third expertise on this. Dr. Jyoti, yes, sir. Yes, sir.
See, what they have done is that the soap which we normally take after our meals. Now, this should be taken, and if you put this soap under the inverted microscope, which all the IVF specialists will have it, in the lab, you'll find there are white spots on it. Basically, these are the, the probiotics, which are there naturally placed. So that is why in our, Indian foods, the soap was a, very important part after the meal. So they said that if you take soap, so you are adding the natural probiotics with the soap only. Secondly, I had mentioned many times, earlier the ladies used to, while going for a bath, they used to carry curd along with them, a spoon of curd, which I tell to all my patients. And they just dab it on their hands and then dab it on their private parts. And then they take bath. And afterwards, they wash the private parts also. So instead of giving something orally and then expecting it to go through the gut, that coming through the innards, through the squeezes, then coming to the vagina, then why not put curd directly, over there only, so that the lactobacilli can directly go inside. So these are a few things, I thought I'll just add it over here, which can be easily done by anyone.
Yes.
So instead of giving costly probiotics, they can apply curd locally and take the soap every day.
Dr. Jyoti Agarwal.
Yes, good afternoon, everyone. Very nice talk, very simplified for such a never-ending topic. Itna simple hai ki not even gynecologists, even it is very good for the patients. All the myths have been cleared beautifully, because many a times when I do ultrasound and I tell them by seeing the picture of the ovary, you have got PCOS and suppose she is thin, she will say, मेरे को कैसे हो गया, मेरी तो cycles भी regular है और मैं तो overweight भी नहीं हूँ. So many a times not only these lean ones have regular cycles, they may even have a shortened cycle also. So we should very clearly distinguish all the phenotypes, and instead of going into those complex 6 types, the best take-home message is that Dr. Chakravarti's slide, what is A, B, and C, to whom the clomiphene is to given, letrozole, or straight away offer IVF for these patients. Very simplified talk in front of gurus and my teachers. I am no expert on PCOS. I have learned so many things in a very simplified way. And thank you, sir, for your soft thing. I never knew this. It's a new thing to me, and I will always remember, and I will advise everybody to have soft after lunch.
We should all also have it.
हमारे कल्चर में बहुत छुटपन से ही बच्चों को दही बेसन से नहलाया जाता था. Maybe that is one of the reason. So thank you, sir, so much. And here I would just like to say one more thing. Many a times when you do ultrasound, you may see that the arrangement is like that of a PCOS. But if the thyroid has not been tested for it, we should also go for a thyroid testing, because if they have hypothyroidism, the picture on ultrasound looks very much like that of PCOS, and that may be another factor for infertility. That's all I have to say. Thank you, sir.
And Dr. I think we will share with jointly myself and Dr. Jyoti Agarwal that whenever you have taken a donor who's less than 40, 38, 36 years, 30 kg weighted, never take it, because if they land up in OHSS, they will really trouble you. So I think one make a dictum that no donor should be taken who's lean.
Yes, definitely. That is one reason. And the second reason is since they are underweight, they are malnourished also. So they don't give a very good quality. The number may be 40, 50, but the quality is very poor for these patients. So I usually don't go for patients who are underweight.
Over to you, Dr. Jyoti Bali. Thank you very much for the time.